Good morning. Welcome to ECG's webinar, Scale is Irrelevant Without Performance. My name is Andy Backroad. I will be today's moderator. Our featured speakers today are John Fink and Alfredo Fernandez Concha. John and Alfredo are the authors of the third of 5 ECG We Believe Strategic Perspective Series white papers. John has been consulting to healthcare organizations for over 25 years. He connects people by finding shared interest and common ground, and he focuses on helping health systems collaborate with physicians to better serve their communities. The diversity of John's experience helps him see the big picture and the perspectives of the many stakeholders involved in the projects he's asked to guide. Alfredo is a senior manager in ECG Strategy and Business Advisory Group. His strong background in finance and strategy helps him create sound, fiscally responsible strategies for healthcare organizations as they seek success in today's climate of constant change. A couple of reminders before we get started. You may submit a question by typing it into the question and answer panel on the right side of your screen at any time. We'll try to get to questions at the end, and if not, we will follow up with written responses to questions to all participants. Please provide feedback through our electronic survey following the webinar. ECG will contribute $5 to Doctors Without Borders for each completed survey. ECG's We Believe series is designed to be a provocative call to action for what healthcare organizations must do now to ensure their sustainability in today's environment, and a future wherein we believe the pace of change and industry innovation will require a change from the status quo. Those of you who attended our first 2 We Believe webinars will recall from our first webinar that we believe we have entered a new era for healthcare, one where we must accept that the journey toward value must accelerate. In our second webinar, we discussed the need to integrate and rationalize to enhance clinical care, optimize operations, and lower costs, ultimately focusing on the improvement of every aspect of patient care operations. Today's webinar focuses on the value that scale can bring to health systems and the communities they serve. We believe scale does matter and is needed to achieve a level of market indispensability characterized by an integrated provider network able to invest in data analytics, bear risk, and offer patient-friendly physical and virtual care settings. But size, or scale, doesn't guarantee relevance. Bigger doesn't result in better. Only those health systems that grow while advancing performance by strategically pursuing vertical integration into asset-light delivery mechanisms and ensuring a deliberate and structured approach to scale will be positioned for clinical, strategic, financial, and operational success. So, John, tell us, why is scale important?
Well, Andy, that's right. We do believe scale matters. And that said, I want to start off by recognizing that it's not the only path to maintaining relevance. And many of the benefits available to those with scale can be accessed while remaining small, or in our lingo, independent. Furthermore, size or scale doesn't guarantee relevance. As you said, bigger doesn't result in better. In fact, healthcare is different in that we have many examples of big systems that really aren't all that good. In other industries, you can't become big unless you're at least kind of good. And they're the very best become the biggest because of the high demand for their products and services. So we're hoping everyone will bear with us a little during today's webinar while we speak somewhat theoretical at first, so we can all understand just what might happen to our industry in the coming years, so we can identify where we should focus our attention now to enhance our position for future success. You know, it seems like consultants and bankers have been telling hospital administrators and their boards for decades now that the pace of hospital consolidation is speeding up. You know, we hear that a lot, right? Back in the 90s, we attributed an increase in hospital consolidation to the rise of managed care. It made sense. Managed care meant we didn't need as much capacity. It changed the bargaining position of hospitals relative to health insurers. And everyone felt like they needed an integrated health system so they could manage care. But looking back, we can see that consolidation wasn't so much about being able to manage care as it was about, one, surviving during a period when inpatient hospital spending was plummeting, and two, gaining power against commercial insurers. This last decade, we've credited the Accountable Care Act with consolidation in healthcare. The rationale has been that getting bigger will allow a health system to assume the risk of the cost of the care of the population it serves. And although improving reimbursement of hospitals that are pulled into a larger health system is still part of the equation for internal decisions for transactions, real focus in efficiencies and performance improvement, and that's starting to be a greater focus. And as a result, health systems are becoming part of the solution to reduce premiums rather than just driving up the cost of care. However, over the last 20 years, mergers among healthcare providers have only occasionally resulted in the benefits that they are professed to be making available. Several studies have shown that healthcare provider consolidation often weakens performance rather than enhancing it. And bigger health systems have been unable to convert their size into operating efficiencies or better outcomes for their patients. Now, we believe that that's changing, and we believe the pace of change will increase as leading health systems set the path for others. The benefits from consolidation to all stakeholders, patients, consumers, employers, payers, are now starting to be realized. Many health systems with scale are starting to perform.
So what do we mean by performance and how do we measure it? It can be measured through a number of different lenses, and we understand that it's multifaceted. For the purpose of today's conversation, we're defining performance as financial health, measured by operating margin, and quality, measured by CMS star rating. Using these measures as guideposts, one can see that larger health systems, on average, provide better care in a more financially sustainable manner than smaller health systems, and we believe the gap will grow. The largest 50 MSAs in the United States account for approximately half of the nation's population. In studying these MSAs, on average, the largest 3 health systems in each substantially exceeded the median performance of all other systems in their markets. As the slide illustrates, the financial performance and quality performance of the largest health systems consistently surpasses overall market performance. But better performance is not only associated with health system size, there is also a correlation between the leader's performance and the market concentration where those systems operate. The median operating margin of the top 3 health systems in highly concentrated MSAs is over 7%. Compare this to a median operating margin of less than 0% across all market participants in markets of moderate and low concentration. Based on these results, one could infer, and they would be correct, that performance is optimized by large systems in highly concentrated markets. Furthermore, the highest performing health systems in the best performing MSAs typically have a combined market share of greater than 80%. And this is the case in 17 of the 20 highly concentrated MSAs.
And it's worth pointing out that, as Alfredo said, this data is focused only on the 50 largest MSAs. So those of about 1 million people or more. So if you're in upstate New York, if you know upstate New York, Buffalo squeaks in at number 50, but Rochester is out at number 51. These are markets where low concentration is actually possible. MSAs smaller than the top 50 tend to have high levels of concentration. Sometimes there's just one hospital or one health system in the whole area. In contrast, 3 of the 4 least concentrated MSAs are New York, LA, and Chicago, the nation's 3 largest MSAs. So by focusing on these larger MSAs, the top 50, we're able to see that high performing, to be high performing, the way we've defined it, it helps to be large and in a highly concentrated market. Now, however, not all health systems in highly concentrated markets obtain higher financial and quality measures than those in less concentrated markets. As you can see on this slide, the median operating margin and the median CMS star ratings for all systems within an MSA did not correlate with market concentration. If high concentration and good performance went hand in hand, then we'd see all the dark dots in the upper right and the light gray dots in the bottom left. But the MSAs are all over the chart. So that previous slide and this slide, really three key insights come from those. One, it's that regional market dynamics play a large role in financial and quality performance for all systems operating in a market. Secondly, large disparities in performance exist between the top 3 systems and the rest of the systems in highly concentrated markets. And as concentration increases over time, something we believe is going to continue to happen, the delineation between market leaders and laggards is accentuated. But these findings aren't surprising. In fact, they're common in most industries, especially more mature ones.
So with few exceptions, firms in many industries benefit from scale, and so do their customers. As many of us most likely learned through either our academic experience in business school or industry literature, the rule of 3 has been analyzed, debated, and applied in various ways since it was first conceived in 1976. Although the rule of 3 is intended to cover an entire industry, our analysis shows it applies to healthcare on a regional basis. In short, markets that have not already consolidated will do so, such that 3 health systems will account for a large majority of that market. The 3 largest health systems will perform better than smaller generalist health systems. And then specialists or niche providers, so think single specialty hospitals, may maintain high performance provided they remain focused on their core competency. Furthermore, we should expect the growth of national and multi-regional health systems to not only continue, but intensify. Finally, the additional financial pressure placed on independent hospitals and small regional providers by COVID-19 is driving many of them to seek the enhanced security of a larger system. So what does this mean for you? A priority for many will be to do whatever is necessary to avoid or get out of the ditch. So this is the space that finds generalists that are not the top 3 organizations by share or are not niche providers providing services that are not easily replicable in the market. Strategic decisions to avoid this ditch will depend on your organization's core capabilities and market position. One must make assumptions by the level of concentration today in the market and the size and specialized services a hospital can offer to its patient population.
So in general, the way to think of this is small systems in unconsolidated markets should either specialize, merge with similarly sized systems, and or seek to be acquired by a system capable of establishing and maintaining scale. Then small systems that are in consolidated markets should be looking to specialize or seek to be acquired by a system capable of maintaining scale. And then for large health systems, large systems in unconsolidated MSAs should be considering merging with similarly sized systems and or pursuing multiple acquisitions of small systems so they can secure their place as one of the largest 3 systems in the regional service area. And then large systems that are in MSAs that are already consolidated, they should selectively acquire or affiliate with the remaining small systems so they can avoid losing their position as one of the largest 3 systems. And then large systems, regardless of the consolidation, they need to be considering mergers across regional markets to begin to establish a national presence. So now, affecting all of this is the entrance of consumer-focused, data-driven companies into the healthcare provider space. So why are hospitals and health systems, as you can see on the left side of the slide, viewed as areas most needed of disruption in healthcare delivery? Why are there a number of non-traditional firms entering the healthcare delivery space, and why now? Well, part of the answer is data and the tools to understand the data. Never before have we had so much data, and never before have we been able to put it to use like we can today to influence behavior and steer individuals to certain care delivery mechanisms. And many health systems don't even realize it, but there's a race underway to secure consumer relationships. Insurers and other disruptors are investing large sums in digital health consumer engagement vehicles. Many of these services are positioned as value-added member services, but ultimately it's to influence behavior, where consumers get their information, what services to use and when, anything to help them navigate the complexities of today's health system, while garnering a strong consumer advocate in the process. And so there's nothing inherently wrong with the current measures of patient satisfaction and engagement. At the end of the day, having patients recommend a provider organization is always going to be a good outcome. In addition, establishing a long-term relationship with a consumer population whose mindset is, I wouldn't think of going anywhere else, that becomes a market differentiator. A health system's brand must be managed to this end.
But we know healthcare is different. It is both intricate and intimate. It's intricate because it's tightly regulated. There's a separation between the person receiving the care and who's paying for it. And there are complex incentive mechanisms that are not always aligned with better outcomes or health. It's intimate in that this is about one's health. We can't lose sight of it. It's not the same thing as shopping for retail goods or in a store, or determining whether you like Hulu or Netflix better. The intimacy of healthcare does not always allow rational, market-driven decision-making done through a typical consumer mindset. So back to our framework, the rule of three applies wherever competitive market forces are allowed with only minor regulatory impacts, and where incentives are aligned for rational decision-making by participants. In summary, it does not perfectly apply to an industry as regulated or with as many complexities as healthcare. With that being said, we still want to ensure we avoid that ditch under all circumstances. So we will discuss how vertical integration into asset-light care delivery mechanisms, exploring new business and product offerings, and developing a structured approach to system performance to ultimately achieve market indispensability, which cannot be done on scale alone.
So, John and Alfredo, that provides a nice academic assessment of the tendency toward market consolidation. I'm sure many of us will remain skeptical that the market for healthcare services will actually consolidate to the degree that most other industries have. In your white paper, you state vertical integration will separate the most successful health systems from those in the ditch. Let's turn towards some of the benefits that vertical integration provides and what you'd suggest most health systems should be thinking about now.
Sure, Andy. A couple points we'd like to discuss are that, one, the growth market in healthcare is the provision of services outside the hospital. Ambulatory services, virtual health, home health. Health systems without a clear strategy to lock up this business are at risk. And two, consumers have more choice than ever before. Health systems need to figure out how to build a connection with consumers. Many have relied on being the only option in town, or knowing that the other couple of health systems in town aren't doing much that would change market dynamics substantially. That's just not going to cut it with new market entrants focused on profitable business lines. So we challenge health systems to pursue vertical integration into asset-light delivery mechanisms, explore new business and new product expansion opportunities in wellness, and employ a deliberate and structured approach to achieving scale.
Well, what's interesting is that owning stuff isn't what it once was. 10 years ago, among the 10 largest publicly traded companies were names like ExxonMobil, PetroChina, BHP Billiton. These are all asset-heavy firms in industries such as energy, mining, and manufacturing. Today's highly valued firms are asset-light companies, mostly firms in technology and finance. These firms generate revenue while owning relatively few fixed assets. Asset-heavy businesses have high fixed costs and require consolidation to build scale and high degrees of efficiency to drive return on assets. In contrast, asset-light businesses have low fixed costs and derive their return on assets from broad, efficient distribution networks. Health systems are burdened by big buildings filled with expensive equipment. Although those big buildings need to be maintained, investments should be focused away from brick and mortar and toward the delivery of ambulatory care, virtual capabilities, and other asset-light services that broaden its portfolio and reach.
So when we say scale matters, number of hospitals or beds or discharges, it's no longer a good way of thinking of scale. Yes, scale does matter, but so does breadth. Many of the most useful applications of data health systems are gathering require a comprehensive network of care. And the more comprehensive the network, the more robust the data. This data will empower health systems to not only understand their patients when they're sick, but also offer insight into the general well-being of the populations they serve. Vertical integration offers that ability. It's rare to find a hospital that doesn't consider itself part of an integrated delivery system or integrated delivery network. To be effective at covering a region, integrated delivery systems need to have an aligned provider workforce, often an employed multi-specialty group or alignment with independent physicians. They need clinical integration among those providers and the ability to cover what we've all come to know as the continuum of care. And sorry, we're talking about vertical integration now, and we have the slide showing the horizontal continuum of care, but I think y'all get the gist. A health system seeking to develop lifelong relationships with its customers, must first make sure it's filling all the holes so patients don't need to look elsewhere for care. So ensuring a comprehensive healthcare delivery system with superior customer satisfaction and convenient physical and digital touchpoints is task one. And that's a big task. Most health systems have a long way to go in developing their digital health capabilities. But that's a topic for the next webinar in our We Believe webinar series. Many health systems also still lack an adequate ambulatory network, and that needs to be fixed right away. Health systems need to invest more in providing services where consumers are seeking them. This slide illustrates the migration of the inpatient setting from the inpatient setting to the outpatient care from 1997 through 2017. Now, this is just showing care in a hospital setting. We can see that inpatient admissions decreased 11% over the 20 years. By the way, length of stay decreased by over 10%. So inpatient days per capita shrank by over 20%. Meanwhile, outpatient visits grew 40% and outpatient surgeries grew 30% over this period. Again, that's just in the hospital setting. Now, you might notice on this graph, the blue line has been relatively flat over the past few years, staying around 106 inpatient admissions per 1,000. Baby boomers are now 56 to 74 years old. So we shouldn't expect the gap on the right side of this slide to continue to widen. But that's not just because inpatient admissions are going to stop decreasing. It's also because outpatient care at hospitals, the gray line, is going to stop increasing. In fact, it already has. If we add 2018 to the outpatient data, we see that outpatient visits to hospitals actually declined from 2017 to 2018. In fact, 2018 was the first year in which hospitals saw a decline in outpatient visits in 35 years. So hospitals are now faced with a situation where inpatient visits per 1,000 have plateaued at about 106, and outpatient visits are no longer increasing. Why aren't they increasing? Consumers have more choice, and they're choosing lower cost, more convenient settings for imaging, ambulatory surgery, and they're going to urgent care centers instead of the ER.
And John, it's not just patient choice. Medicare, commercial payers, and employer groups are demanding reduced healthcare costs. Employer groups are tracking their healthcare spend and holding payers accountable, comparing cost differentials between sites of service, and demanding accountability from payers. Providers must be responsive and proactive as payers and employer groups seek alternative sites of service and also seek providers that can demonstrate value and the ability to reduce costs while also offering high quality care to their members and employees. So as an example, surgery is one of the most expensive cost centers in the hospital, but it is also one of the highest revenue generators. The momentum to support and direct surgery out of the hospital setting to ASCs presents significant opportunity for CMS and commercial payers to realize savings. On the flip side of the payer-provider coin, this presents a significant threat to the financial health of a hospital or health system if a sound ASC strategy is not in place. However, it also provides opportunity. Policies and benefits that financially incentivize and reward providers for delivering cost-effective care are growing. These changes circumvent physician employment by hospitals and mitigate primary care strategies. As rules and policies change, technology and surgical techniques advance, this trend will continue to accelerate. But what else? Let's say we're investing in ambulatory services. Do we have convenient locations where high value care is provided? Are we expanding our reach either directly or through closely aligned partners? Are we covering the continuum of care? Maybe you're already covering these items. However, we also suggest that health systems should expand their perspective of the services they should be providing to their communities.
Yeah, rather than limiting the health system to the traditional continuum of care and those services reimbursed by traditional payers, we suggest thinking of vertical integration whereby instead of a continuum of care, we move to a continuum of life, where health systems' roles are to partner with consumers in achieving and maintaining what we call health actualization. So think of all things affecting health and wellness, from cradle to grave or womb to tomb. Those should be considered in play for a health system, no matter how large or small the health system is. I'm sure Andy can appreciate the in search of reference here. It might be before Alfredo's time, but profitable growth among health systems has been as elusive as the aliens and Bigfoot and the Loch Ness Monster were during the In Search of series with Leonard Nimoy back in the 70s. For businesses, we've always been taught to focus on the core, right? But as new competitors enter the industry and take pieces of the few components of the core that are profitable, health systems need to move beyond the core to find new sources of revenue that provide much higher margins than they receive from their historic core business. And vertical integration allows this. Some health systems have been on this path for years. Ascension Ventures has limited partners in 13 health systems, investments in nearly 75 companies, and over $800 million in assets under management. Providence Ventures, Northwell Ventures, UPMC Enterprises, these are all examples of the dozens of corporate venture capital funds health systems have developed to invest and grow businesses. But a health system doesn't need $100 million sitting around to create a corporate venture capital fund to diversify its revenue base. When seeking new sources of profitable growth, we recommend: one, explore opportunities that align with the organization's mission and vision. Two, evaluate whether to build, partner, or buy into that new revenue stream. And then third, manage risk tightly and investment need to support a well-vetted, long-range financial plan.
And John, as one can see on the left-hand side of the slide here, many socially rooted elements are top of mind for health system executives. Social determinants of health issues such as transportation and food insecurity rank towards the top of non-clinical barriers to health, of which systems plan to take action in the coming year.
Yeah, and some of these services can be turned into profitable businesses, more profitable than a health system's core business. New sources of revenue with higher margin potential than a health system's core business become apparent when the health system considers itself part of the $4.5 trillion global wellness industry. You know, these are growing markets where smart investors are allocating capital. An expansion of the scope of services provided either directly or through affiliations allows a health system to fortify its relationship with consumers and to increase profitability. Before we move on from this slide, I live in San Diego. Here, the health system is pretty much Scripps, Sharp, UCSD, and Kaiser. I don't have much of a relationship with any of them. Now, I'm getting older, so I now go to the doctor every couple of years. It used to be much less frequent, but I've always gone to my optometrist every year. I see my dentist twice a year religiously. Some people go to a hairdresser or a barber several times a year. Obviously, if you noticed my picture at the beginning of this webinar, I don't bother with barbers, but I do go to my health club pretty much every day. Went there this morning. Well, why don't Scripps or Sharp and the others connect with me more frequently by operating optometry and dental practices? Why not at least hang a shingle at my health club to provide physical therapy there? Or better yet, manage the personal training there. There are all sorts of tangential businesses healthcare providers should be pursuing.
So there are multiple ways in which to pursue those business opportunities. The decision to build, buy, or partner a health system's growth into asset-light revenue streams will depend on a myriad of factors. Those can include the long-term vision for the product or service, internal capabilities, availability and value of potential partners or acquisitions, the competitive environment, branding preferences, capital needs, to name a few. Chief among a health system's considerations is the urgency with which it is seeking to enter the market and the degree to which it currently possesses many of the capabilities to build a business. So starting in the upper left-hand corner here, build when your organization already has many of the core elements of the new business. While this option is capital and time intensive, it allows the system to define the scope and breadth of services, size of the edifice, and personalization of design to satisfy community and organizational goals. Now moving to the opposite corner, buy when there's a high urgency to enter a market and your organization has low capabilities to perform well. Barring the need for cultural alignment after acquisition, buying a business allows the health system to tap into rooted community relationships and network affiliations. The top right-hand quadrant is partner. Most viable, profitable growth opportunities that fit within a health system's mission will lend themselves well to partnering. Fortunately, partnering is second nature for most systems. Partnering can occur through joint ownership or contractual agreement. The typical health system has dozens or even hundreds of management agreements, service agreements, joint operating agreements, and joint ventures. Partnering allows a health system to achieve additional scale without heavy investment capital. Overall, partnering allows to reduce an investment's risk profile. So lastly, on the bottom left-hand corner is reconsider. If your system doesn't possess many capabilities and there's low urgency to move into the market, then it's most likely a time to focus on other priorities.
Okay, so the title of this webinar in your white paper is Scale is Irrelevant Without Performance. You've explained some reasons why scale is important and given us some ideas on how to pursue scale, not just horizontally, but especially through vertical integration. But can you speak to performance a little further? What do organizations that are scaling need to do to also reach a level of meaningful and sustainable performance?
Well, Andy, that's not an easy question to answer, but part of the answer is contained in the webinar John Lutz and his team gave just a few weeks ago on integration and rationalization. Part of it is going to be answered during the webinar Darren Livy and Asif Shah Mohammed will provide on digital health in a few weeks. For now, we want to talk through 5 recommendations or guiding principles for achieving system performance. So we'll just talk through each of these. First, don't look for scale to create performance. Achieve performance and then scale by integrating new organizations and new growth into your high-performing business. Those health systems that cannot enhance the value they provide through higher quality and lower costs, aided by advanced analytics and artificial intelligence, they're going to fade away or be absorbed into those that can.
The second one here is engage physician leadership to drive system-wide reduction in care variation. Physicians throughout the system should be supported by centralized and regional personnel to enhance clinician-to-clinician collaboration, maximize use of clinical information systems, and design, develop, and implement solutions to reduce variation and spread innovation. Physicians need to be empowered with timely cost, quality, and outcomes data that can support consensus building and guide decision-making.
Okay. The third is optimize centralized shared services. Now, this is just doing the simple stuff well. Or, I don't know, I guess it varies. Some people don't think of it as a system, but it's the core work of a health system, right? Standard non-strategic functions like rev cycle, patient contact centers, supply chain, finance, legal, HR, IT, all that stuff should be managed at a system level. Although economies of scale through cost cutting are not a compelling reason to merge, the nuts and bolts of operating the health system must be optimized. And organizations added into the system through acquisitions or mergers must be effectively integrated into that shared services structure.
The next one is to establish an effective consolidation strategy. And we're going to go into some detail here. So first, it is important to define the one core objective driving your consolidation strategy, and then measure every opportunity it supports on that objective. Once a core objective is identified, 4 common consolidation strategies could include rationalization. So this is combining with a like system and allows the system to achieve a more efficient use of assets. A market consolidator must be able to take organizations that will never achieve great performance on their own and fold them into one that can. A turnaround strategy often involves a target provider organization that's seeking a partner from a position of financial distress. This can be a difficult strategy, and the integration plan for the acquired company must rely on more than just simply enhanced payer contracts and cost reductions. Another consolidation strategy is scaling expertise. So a danger of vertical integration is expanding into a sector in which the system leadership may lack necessary expertise. However, the acquired company's management team may have the capabilities to not only continue to operate its existing business, but also expand that business across the broader footprint. Lastly, there's scaling innovation. Corporate venture capital funds have become commonplace within major systems. Many invest in emerging companies in key growth areas such as patient engagement, population health management, and digital health. Organizations can serve as an incubator, an initial customer, and a resource to understand how to refine those products and offerings.
So we're saying in general, establish an effective consolidation strategy. You need to have one core objective that drives it. It might be tied to one of the 4 strategies for value creation that Alfredo summarized. It might be something else. The priority is to avoid having multiple reasons driving a variety of types of transactions. Now, the 5th principle is align culture, strategy, and brand. System performance is contingent on the system having a unifying culture. Not one culture for the hospital, second culture for the medical group, and separate cultures for all the different facilities or regions. We as consultants often see these separate cultures within a health system. It's what causes, for example, the medical group people to not support the hospital's alignment efforts with an independent medical group. They have different cultures and different strategies. As a result, they fail to perform as a system. When a singular culture does exist, it must be complemented by the system's branding, or really vice versa, or together. When culture, strategy, and brand are all aligned, all stakeholders understand the health system's purpose, and that purpose guides all behaviors, decisions, and interactions. As a result, the experiences of patients, consumers, employees, physicians, donors, volunteers, they're all connected and consistent throughout the organization.
So in summary here, we believe health system scale is irrelevant without performance. The drive to achieve scale is not new for health systems or other participants in the sector. However, successful achievement of scale is not defined by number of beds, total size, or number of acquisitions. Health systems must translate scale into performance as measured by increased revenue, reduced costs, better health, and top quality and outcome measures. Historically, the largest systems in highly consolidated markets have outperformed the market. Many of those high-performing health systems have successfully achieved scale over decades. However, consolidation will continue to accelerate due to a number of factors, including the availability of data and data analytics to inform decision-making, increasing financial pressures on smaller hospitals' ability to remain independent, and growing competition from non-traditional market entrants into financially attractive, asset-light, ambulatory, and ancillary services. Despite its risk, traditional and horizontal integration may still help reach a desired level of market indispensability if following the rule of 3. However, health systems must avoid the ditch and create a level of market indispensability by creating an integrated provider network, pursuing strategic growth opportunities, so think vertical integration, offer value, and that could be whether you're bearing risk or not, be consumer-centric through access and the ability to offer patient-friendly physical and virtual care settings, and finally, be data-driven in strategic, operational, and financial decision-making.
So we're leaving you with 2 frameworks to think about. The previous slide covered 5 guiding principles to achieve system performance. This slide covers becoming essential. The point is that you need to do both, perform and become essential. Right now, there are health systems that are essential because of their size, but some of them are not performing well. Their failure to perform is putting them at risk of falling into the ditch. And there are well-performing small organizations. They might be able to stay focused on their niche and survive, but many of them will find themselves in the ditch if they don't find a way to become essential through scale.
So before we move on to our questions, let me give a reminder to our audience to please continue to enter your questions in the questions pane, and I'll ask as many of your questions on your behalf as time permits. So, well, John and Alfredo, you've covered a lot. We've had several questions come in during the webinar, but before we move on, let me just talk about a couple of these other questions that have come in. One is from a listener who asks the question, what about market disruption? We didn't quite follow the comments on slide 13, and as I flip back here, it looks like they're referring to the slide with logos of several new entrants and how they could disrupt the market.
Yeah, sure. Let me take the first crack, and let me tie this to the rule of 3, because pick an industry, airlines. At one point it was United, Delta, and American, but then Southwest disrupted that. Or more dramatic, big coffee sellers. My wife's a big coffee drinker. At one point it was General Foods, Procter & Gamble, and Nestle. Collectively, they had 90% of the US market. Then came Starbucks, and now it's Starbucks, Dunkin', and the company that owns Pete's and Caribou and Panera. Those are the big 3 now. How'd they get that way? Well, they performed. So players change. And just because a health system is serving a community for 100 years or more, it doesn't mean that they'll have the same place in the future. In this webinar, we're measuring health system size using revenue, and that makes sense. But to be included in our analysis, you have to at least own a hospital. Optum could be the Southwest Airlines or the Starbucks. It could flip the concept of market share for healthcare providers. Remember when I said Buffalo and Rochester each have about 1 million people in their MSAs? Well, that's 1 million people spread across a bunch of different healthcare providers in those markets. Well, Optum cares for over 1.5 million people just around Los Angeles. Nationwide, Optum has 50,000 affiliated physicians, over 250 urgent care centers, and about that many ASCs. Those are the asset-light investments that we were discussing earlier. And Optum definitely knows how to put data to use. You know, it's a $112 billion company, and Optum Health, the division that's focused on care delivery, care management, wellness, and consumer engagement, it generates over $30 billion in revenue. It's the largest health system that no one calls a health system, and it's much further on the path of functioning like a system than many traditional healthcare provider organizations.
That's a good segue into this next question. And this is, you discuss asset-light delivery mechanisms. However, what are the actual benefits to an asset-light approach?
John, I could take this one since you got a kind of first pass to the last one. Yeah, it's a good question. We did touch on this a little bit. And so there's a couple benefits. You're moving to where the market's moving, so that those are ambulatory services, which are asset light. You know, one could potentially be moving from a lower margin service to better margin. You know, kind of think back to it's all about profitable growth. And then I think that, you know, another big one here is with an asset light approach, you can essentially help build relationships with consumers outside the four walls of a hospital and really kind of focus on that consumer base.
I'd add in that the whole point is for you to have more frequent interactions with your consumers, whether those are in person or virtual. So this expands the ability to engage and understand your consumers outside of the traditional four walls of a hospital.
I'm going to ask a follow-up question on this topic of asset lightness, because we've had a couple of questions come in from our listeners. So, and I'll let either John or Alfredo take this as they prefer. So here's the question. While asset lightness is an interesting concept, healthcare does still require highly trained staff, specialized equipment, and highly controllable patient environments to address complex care episodes. Is our assertion that healthcare must become asset light a concept toward financial health or characteristics along a continuum of asset types?
Is it, ask that last part again, Andy.
Is it our assertion that healthcare must become asset light a concept toward financial health? So in other words, if I can infer from the question here, must we become an asset light or model care delivery system to drive financial health, or is it one of the characteristics along a continuum of asset types? So in other words, a question would be, should we have an asset heavy strategy, but also continue to be in the, I guess the asset heavy model of the hospital?
Yeah, so because I kind of think of it as health systems, most health systems, the way we define them, are still going to own big buildings, right? And it will be a component of their assets that are used to deliver services, right? And so you can start to think of yourself as a conglomerate, as Alfredo was showing you the shift of big companies out there. And some are, these conglomerates, they have some asset heavy businesses and some asset light businesses. What we're saying is, and there will always be a role for a hospital, right? And the danger that a lot of organizations that are hospital focused, they're going to, in some markets, become, just a vendor, somebody who's taken care of, and the risk is that you end up being a price taker, right? And there are places in our country where that's what many hospitals are. They take whatever the IPA or the payer is going to provide. And so what we're telling you to do, I think it's that continuum of, well, yeah, you may have some low margin areas of business and some high margin areas of business. The danger is most health systems have too much of their assets tied up in delivering low margin business, and they need to shift to making it so they have some other sources of revenue that generate a higher percentage, basically a higher margin on that, so that they can continue to survive.
Yeah, I would add, it's not really about becoming an asset light provider, but it's really the investment into those asset light mechanisms. I mean, I think the biggest risk here is for health systems. You want to focus on your core capabilities, but you definitely don't want to get disintermediated with all these other kind of players that are entering, and even some of that low acuity, that could start to get redirected to other providers and would cause kind of an issue from a market share perspective and financial perspective for health systems.
Okay, thank you. I think we have time for two quick questions. One I'm going to come back to. It's a question that came in around this concept of what's driving the margin of these better performing systems. So what's our perspective on how much of the difference in margin is driven by pricing power via consolidation, creation of systems, versus the improvements that are driven through efficiency and cost structure by way of consolidation? John or Alfredo, do you have a perspective on that?
You go ahead, John.
No, you go for it.
Yeah, that's a good point. We kind of write out a big answer to that. I mean, a lot of the kind of analysis we had up front here, historically probably has been done through better contracts, and there has been some efficiencies that have been driven on the cost side. So that's definitely playing a role. I don't know what the breakout is between the two. We'd have to drive into a little bit more. I think going forward, though, as we think about scale and performance, it can't just rely on that buying power or just continue to squeeze costs here and there incrementally, but really focusing on things like organic market share growth. So, some of that is an investment into those asset-light services or other kind of product services. Continue to focus on reduced costs, and then just generally better managing a population.
Yeah, a lot of health systems have been investing a lot in population health and their physician enterprise, right? But they haven't been passing a lot of that, as far as the savings on to consumers. But that's probably going to change. So, especially with regional systems, as you start to rationalize and optimize the clinical portfolio, there's opportunity to drive scale and then have that result in lower costs and better outcomes.
Okay, thanks. Last question. What are some ways in which scale can be undermined?
So I think this is simply failing to do the right thing to achieve system performance. We see situations where not everyone's rowing in the same direction. We have regional health system clients out there that have multiple hospitals in the same geographic area as one another, and they compete as hard against each other as they do with the other hospitals in the area from different health systems. Sometimes they compete harder with their sister hospitals, and that's just a failure to perform as a system. Often incentive structures are non-supportive of operating like a system. For example, the hospital CEO whose compensation is tied to the performance of their hospital instead of the performance of the region or the system. For many hospitals, probably most, they're in the midst of this journey from moving from a holding company model to an operating company model. So to get back to the question of how scale can be undermined, well, there's lots of ways. And the real question is whether system leadership is ready to address them and make the changes needed to remove those who are putting up the barriers to systemness.
Great, good answer. Thank you very much. Well, that concludes our formal program. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to reach out to one of us via the contact information provided in the handouts. And one final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a good day.